Hello everybody, my name is Yahya Ithawi. I'm a consultant neonatologist, and this is the third session of the neonatal resuscitation as a part of half academic days for neonatal perinatal medicine fellowship. Last session we were talking about, which is the second session, we're talking about the sequence of intervention should be taken to help a baby during resuscitation. And in this session, we will continue the intervention. So the first time we assess is we're looking if the baby is breathing spontaneously or not. So looking at the breathing status. If the baby is breathing spontaneously, then we assess or measure the heart rate. And if the heart rate is more than 100, then we go to the second, which is assessing the overall color of the baby, whether it's pink or not. And also, if the pulse oximetry is connected, we look to the saturation. If the breathing or the heart rate or the color / the oxygen saturation is abnormal, then we need to take very effective steps to correct these. And we give ourselves up to 30 seconds and then we assess again. If we do a very good support at this stage, we will help the baby to transition effectively and improve at this stage and do very adequate progress and prevent further deterioration. By doing so, by providing help at the beginning, we will avoid complications that result in further deterioration of the babies, like laryngospasm or cardiac arrhythmia, especially with associated when we do deep suctioning. Also, it might affect complications such as result from hand ventilation. And we can provide a certain effective intervention for specific circumstances. Some of these circumstances that require specific intention in babies breathing spontaneously, but the heart rate is more than 100. And the color is said probably okay, or it was off color but become more pinky and a score between 8 and 10. And there's this situation when the baby spontaneously breathes and heart rate more than 100 and Apgar score between and usually there is no need to support the baby, and the baby should transition by him or herself in most of the cases, and the mean time for them to recover is about 10 seconds. The baby in this situation does not need more than warming, drying, positioning, and mild or superficial and suctioning. After doing that, and after 30 seconds, if the respiration, heart rate, and color know, this initial assessment can be done, and this resuscitation is finished, and the baby can go to the mother's chest. Most of the infant in such situation will establish spontaneous breathing. They only need tactile stimulation, and the stimulation should be very careful and should be not causing further complications. Of such stimulation is vigorous flicking of the sole of the feet or rubbing the back. And when talk about stimulation, we are talking about primary apnea. Remember, when the baby goes to secondary apnea, continuous stimulation will not help. So being more aggressive with stimulation will not prevent the secondary apnea. At this stage, the baby needs effective ventilation. If the breathing does not start after few tactile stimulation, remember the baby in secondary apnea and he needs effective ventilation. Remember, always when you have a baby with apnea, always think it's a secondary. Even if you are over-exaggerating the diagnosis, and it's better because you will give spontaneous or effective ventilation and will prevent you from continuing stimulating the baby ineffectively. If the infant breathing spontaneously and the heart rate more than 100, but overall color is a little bit off, when we're talking here about an Apgar score of 5 to 7, then this situation usually rare, because more than 100 and the heart rate is more than the heart rate is more 100 and spontaneously breathing are likely to happen, and rarely causing secondary apnea. At this situation, we should have a pulse oximetry to assess the color. If the color is off, or we are subjectively labeling the baby as off. Most of the situation, the pulse oximetry needs about 30 to 60 seconds to give us reading. If the saturation below the level of the targeted range of saturation in the table, then this baby might need some oxygen support, such as by blow-by. And usually we give it in a range of 30% and about 5 liters per minute. We can use mask or by tubing held, or using hand, or tubing held about 1 centimeter away from the mouth. If saturation improved and rise within the targeted range in the table of saturation, and then the baby should be weaned from the oxygen slowly. If not, then initiation of CPAP as early as possible is highly advocated. So in infant who is spontaneously breathing and the heart rate is more than 100, in Apgar score somewhere between 5 and 7, the studies shown that early starting of CPAP for a short period of time is equally effective in preventing chronic complication and oxygen requirement after admission to the NICU at the 36 weeks corrected post-menstrual age, is as effective as initial intubation and mechanical ventilation in babies less than 29 weeks. So early CPAP used to reduce the need for effective ventilation by intubation and mechanical ventilation, and also reduce the need for exogenous surfactant administration. However, the study is said that there might be increased incidence of pneumothorax, and we need to be careful about that. So in spontaneously breathing infant with respiratory distress, use of CPAP in delivery is a very reasonable alternative to intubation and ventilation. It's always better to use pressure-regulated mean of administration, whether it's a TB's resuscitator or ventilator, or if possible, you have flow variable CPAP. However, if you're used to a certain device of CPAP, use it in your organization. But I would personally prefer variable flow CPAP than TPs or ventilator-generated CPAP. The other category is you have infant with apnea and the heart rate is dropping below 100 despite the provision of effective assisted ventilation, and your Apgar score is somewhere between 0 to 2. In that situation, if the heart rate below 100 and above 60, then positive pressure ventilation should be continued, and if the baby was on CPAP, then should be switched to positive pressure ventilation, and do that for 30 seconds. And then after assessment, after 30 seconds, do assessment to assess your initial resuscitation steps. Make sure that your ventilation is adequate when you do positive pressure by ventilation by hand or by TPs, and you should see a good effective chest movement, and also you have to listen to the air entry and look at it equal or not. The baby should be ventilated about 40 to 60 respiratory cycle per minute, using the minimal pressure needed to observe a good chest rise. And when listening to the lung, you should see effective symmetrical breath sounds. There are certain situations where you might need higher pressure, such as RDS, pulmonary hypoplasia, and when the abdomen is pressing on the diaphragm, causing limitation of lung inflation. Your equipment should be checked always during the ventilation, positive pressure ventilation, and the most important part is the seal between the mask and the face. When you do that, the positioning of the infant head is important, and always you should check and reposition the head when needed in a midline. And you should put the baby head and body in a way to clear the upper airway for good seal and effective ventilation. If the infant is still apneic and the heart rate below 100, despite 30 seconds of good ventilation and the Apgar score somewhere between 0 to 2, you might need to increase the oxygen up to 100% if you did not do so earlier. You should continue effective hand ventilation with 100% for 15 to 30 seconds. The most important measure of is infant, to assess your response is the infant response. If despite good air entry, good chest rise, the heart rate continue to fail and the color or oxygen is poor, then at that point consider intubation. When you do so, always make sure that you rule out pneumothorax. If the infant is apneic, the heart rate below 100 is by 30 seconds of assisted ventilation and Apgar score, and the baby is not improving, then the intubation is absolutely indicated. However, certain situations you might need to intubate earlier, such as diaphragmatic hernia. Use of alternative airway is recommended when your bag and mask is ineffective and you don't see a chest compression. And also you do that when you don't have people are skilled in intubation. Also the ATT help you to administer drug and also secure a good airway for transportation. Remember that bag and mask can do a great job if you cannot intubate. And if you don't have people with a skill of intubation, repetition of intubation is not advised. And remember, bag and mask ventilation can be as effective as intubation. So it's preferred to do effective bag and mask ventilation, waiting somebody who's more effective in intubation rather than repeated trials of intubation. The other alternative, and if you don't have skills of intubation, is laryngeal mask airway. So again, in situation where the infant is apneic and the heart rate is less than 100 despite of 30 seconds of assisted ventilation with low Apgar score, the intubation is indicated and should be done by a skilled person. If despite that, if the cause of the heart rate deterioration due to ineffective ventilation, having the tube in the airways should increase the heart rate to more than 100. If that not happen, then make sure that you're doing effective ventilation and you're actually in the trachea. You can do that with auscultation of the chest, but also you can do it with carbon dioxide monitors such as calorimetric detectors or even capnography if sometime an ultrasound need to be used if you have skill to do this. The key to effective intubation is knowing the landmark and the relation of landmark of the upper airway and the relation of the laryngoscope to these landmarks. How this one can be done? The chin, the sternum, and the umbilicus should be aligned in a single plane. After opening the mouth and inserting the plate of the laryngoscope inside the mouth, the laryngoscope handle and blade are aligned in that plane, and you should lift the laryngoscope vertically in 60 degrees to the baby's chest. If you do so, then there is 4 important anatomical landmarks, which is posterior part of the tongue, vallicula and epiglottis, larynx, including trachea and vocal cord and esophagus. If the laryngoscope is a little bit long and obscuring your view, you can take and include the tip of the larynx with the tip of the plate. If you are too far in, you should withdraw back to see the larynx. If you see one side, you need to align yourself in the middle. It's important to remember that when intubating, you should see as big as possible the upper airway. If you see more than 50% of the upper airway on vocal cord, then the ATT should be inserted under direct visualization. Avoid inserting the ATT blindly. If you make sure that your ventilation is effective and you're providing airway to the lung and the tube is in effective position after 30 seconds of 100% oxygenation of the heart rate below 60 beats per minute, then cardiac massage is indicated. The best technique is to encircle the chest with both hands and placing both thumbs together over the lower part of the sternum. The other fingers should wrap the chest, including supporting the back. If that infant at this situation is intubated, and it's preferably to be so, the effective chest massage can be done easily in coordination with ventilation. And it's better to the one operator or one resuscitator control the ventilation and the other one do the chest compression. When encircling the chest between hands should be done from one side to give access for other person to assess the heart rate and also to insert an umbilical catheter if needed. And that can be done by either standing at the side of the chest facing the head of the baby and the person controlling the ventilation, or facing the baby leg background and inserting the chest in upside down, the first method. So you're either facing the head of the baby and the person controlling the ventilation, or you're facing the leg of the baby and facing the person who's checking the heart rate and placing an umbilical catheter when needed. In either method, the most important is due to chest compression. The coordinated chest compression and ventilation is a little bit different one ventilation alone. In ventilation alone, we do about 40 to 60 breaths per minute. However, here we have to do about 120 events, about 30 breathing and about 90 chest compression, and that can be done as follows. So the person who is doing the chest compression can say 1 and 2 and 3 and the third one say breathe and. So it looks like that. 1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe and 1 and 2 and 3 and breathe. So you say 1 and 2 and 3 and the other person said breathe and 1 and 2 and 3 and the other person say breathe and so on to coordinate the breathing. To assess the effectiveness of chest compression, somebody should check. One person who assigned to insert an umbilical catheter can assess the femoral or brachial or umbilical cord pulse. For each period of 45 to 1 minute, we can stop for a few seconds to assess the chest compression. If the heart rate does not go above 60 after effective ventilation, and then medication need to be considered. However, if the heart rate goes above 60, then chest compression should be stopped, and we continue hand ventilation. If the baby is continue need for hand ventilation, then consider connect the baby to ventilator and transfer the baby to the NICU. And then assess accordingly for spontaneous breathing and need for surfactant and so on. However, if the baby is markedly depressed and need continuous chest compression and effective ventilation and need vigorous resuscitation, then medications, then we need another person to insert the umbilical catheter and consider giving medication. If the umbilical catheter can be done within few minutes, then we can administer the medication. Otherwise, we can administer the medication through ETG. So if after adequate effective ventilation with 100% of oxygen and chest compression for about 1 minute, maybe up to 2 minutes, then chronotropic and inotropic agent need to be administered to support the myocardium. And you might need also to consider giving fluid bolus and correction of acidosis. These medications provide substrate and stimulant to the heart to work, and when the heart works, it will support the circulation of oxygen and nutrition to the brain. To give the medications, you need a working weight. So it's a good idea, if you cannot weigh the baby, to use a working weight as a judgment call of 1, 2, and 3 kg. By this, I end the third session of resuscitations for neonatal fellow. And this is a list of suggested reading. I hope to see you in the next video on this third session and the fourth session of resuscitation. I'm Yahya Ithawi, and have a wonderful day.